This module is going to cover the use of the King Airway in the pre-hospital phase. The two models of the King Airway available to Trauma 1 are the King LT-SD and the King LTD. The main difference is that the LT-SD has a port that can provide suction. The King Airway is a supraglottic or an extraglottic device, similar to an LMA, an iGel, or a combi tube. And what that means is that the device sits above the glottic opening, so it doesn't actually go through the cords. Additionally, it is designed to be placed blindly without the use of a laryngoscope. As you can see, the King Airway includes two different balloons, one that sits in the esophagus and one that sits above the airway. Now, different from the combi tube, both of these balloons are inflated with one single port. To make sizing easier, the King Airway is color-coded and based on the patient's height. The King LT-SD, which we'll use for adult patients, comes in size 5, which is purple, for patients above 6 feet, size 4, which is red, for patients 5 to 6 feet, and size 3, which is yellow, for patients 4 to 5 feet. In the King LTD, which we'll use for pediatric patients, comes in size 2.5, which is orange, for 41 to 51 inches, and size 2, which is green, for 35 to 45 inches. Now, the volume of air needed to inflate both balloons is more than we're used to with normal ET tubes, with about 60 cc's of air being needed for the adult King Airways. The volume needed for each color will be noted on the tube itself. Now, the following videos are from two different groups. First off, AMBU, which makes the King Airway, and next MRAP, which is a popular emergency medicine podcast. They'll go through the basics of the King Airway, including how to place it.
It's available in two iterations. The original version was just a single lumen. It's actually the King LTD, laryngeal tube disposable. It has two cuffs and ventilatory openings in between. The other version, probably the more popular version now, is the King LT-SD, and the S actually stands for suction or secondary lumen, so it has an extra lumen to allow accessing the stomach.
Now, there are two balloons. The more distal balloon goes into the esophagus. It's an esophageal intubation. And the more proximal balloon, which goes in the hypopharynx. There's two main ventilatory outlets, and there are two side eyelets, one on each side. There's also a gastric port, which is made to be able to pass up to a size 18 French gastric tube right there on the side. Again, this is a blind esophageal intubation. So when you inflate the balloons, one's in the esophagus and the other is in the hypopharynx, which puts the ventilatory outlets right over the glottis.
So how this works is you're just inserting it blindly. It's a supraglottic device, and you're wanting to put the tip into the esophagus. And in this case, it's going around the bend, and the distal balloon is sealing in the esophagus, and the proximal balloon is sealing above the airway in the oropharynx. And when you inflate both cuffs, it seals off those respective areas, and you can see the airway openings are here ventilating the airway. So that's how it works. Do a chin lift and control the tongue. Introduce the tip at roughly a 45-degree angle. And with one free and easy motion and without exerting undue pressure, advance the tip behind the base of the tongue, rotate it back to the midline, and advance the connector to the teeth. At this point, inflate both cuffs with a full syringe, 60 cc's, 60 to 70 for adults, 30 to 35 for the pediatric sizes. Connect the resus bag or breathing circuit in the OR and assess ventilation. And if you do not get an airway, retract slightly until breathing is free and easy flowing. If there is a slight leak at this point, you may need to actually add a little bit more for those larger patients. And at this point, it would also be good to use tape or other accepted fixation to make sure that the tube is stabilized before moving the patient.
Or if you prefer, you can use a laryngoscope. Now, when you pick up the King LT, pick it up from the connector, and you're going to insert it using a lateral approach until you get past the tongue, and then bring it to midline Insert it until the connector is at the teeth.
And then for the version with a gastric access port, clearly if you would like to, or it's indicated to pass a gastric tube and decompress the stomach, now is the time to do that as well.
To finish up, look at some real footage of the King Airway being placed in the operating room.